Okay, good day, evening, everyone. Welcome to our seminar. My name is Hiba Jaberti, Healthcare Empowerment Specialist at Saudi Patient Safety Center. You will be hearing a presentation from Prof. Shenyushiro and Mr. Abdullah Zahrani. They will be speaking to us on evolution of National Adverse Events Reporting and Learning System. Prof. Yoshiro is a
Yes.
Chief Patient Safety Officer in Kyosho University Hospital, as well as an executive board member of Japan Council for Quality Healthcare. He has also engaged with international commitments to G20 Global Patient Safety Leaders Group lead by Kingdom of Saudi Arabia, World Health Organization, and International Society for Quality in Healthcare, ISQA. Also, we will move to our next speaker. Also, Mr. Zahrani is an experienced healthcare leader with over 15 years in patient safety and healthcare quality. He holds a master's in healthcare and hospital administration and certification including CPHQ, ACCS, and RRT, MPS. As also, he works as a director of patient safety and risks management at at Saudi Arabia's Ministry of Health. He has led key national initiatives, including the enhancement and rollout of the Ministry of Health Sentinel Events platform. Kindly, just a quick reminder, the question will be posted in the Q&A icon. Now we will be moving to our start of our session. Please welcome Dr. Shen Yushiro. Dr. Shen, the floor is yours.
Thank you. Thank you very much, Heber. And Assalamu alaikum, everybody. And good afternoon, good evening, good morning, depending on your location. My name is Shin Shiro. I am from Japan Council for Quality Healthcare, which is an accreditation body in my country, as well as running the reporting and the learning system. And I also work in University Medical Center called Kyushu University Hospital, where I work as a patient safety officer, chief patient safety officer, and the deputy director of the hospital. And as Hiba kindly introduced, I work as a member of Accreditation Council of the International Society for Quality Healthcare, dubbed as ISQA. And I used to work as a board member of ISQA for 2 terms. That means 6 years. And the last but not the least, I'm a country representative of G20 Global Patient Safety Leaders Group. And to begin with my presentation, I would like to slightly touch on the G20 Global Patient Safety Leaders Group in the next slide. Oh. I'm trying to let me stop my sharing and do it again because my slide is not moving. So let me do it again. I'm sorry. Thank you for waiting. Okay, and then I'm going to share my slide again. I'm sharing my slide again. Okay, and then go to the first slide, and then go to the second slide. Okay, I hope you see my presentation slide on page 2. The Global Patient Safety Leaders Group was established on occasion of G20 Summit in your country, Saudi Arabia, in 2019. It is not evidenced in this document. which is G20 Health Ministers Declaration. It reads out that we welcome the establishment of Global Patient Safety Leaders Group. And ever since, I have been a member and country representative of Global Patient Safety Leaders Group. Although our group suspended our activity on patient safety promotion during COVID-19 pandemic. However, this year we are rushing to promote patient safety activity to continue our work to the next G20 Summit Health Minister meeting in South Africa. Well, this is the health minister's declaration issued last year in Rio de Janeiro, Brazil in 2024. In preamble number 4, the declaration states that we affirm our support for the global antimicrobial resistance research and development hub, the Global Patient Safety Leaders Group, etc., etc. So the momentum of this group still continues and will continue to the next G20 summit in South Africa. So I have been working with Dr. Abdullah Al-Hazawi and Dr. Ali Asseri and Ms. Lamia Al-Hazani of Saudi Patient Safety Center. So I really appreciate this opportunity that your country, Saudi Arabia, made happen. Then I'm going to the next slide. Okay, here you see the photograph of the Kyushu University Hospital where I work. The hospital is located in the city of Fukuoka, shown here, and it's close to Korean Peninsula and the mainland China. And then next slide. And as I said, I have another workplace in Tokyo, which is an accreditation body, JQ. And here, the JQ is located in Tokyo. And I go to Tokyo by air every week. And here you see the project lineup of JQ. And the JQ was originally founded to promote hospital accreditation. And then as patient safety was growingly concerned and focused in our society, so we grew our project lineup to include national reporting and learning system that targets hospital, clinic, community pharmacy, dental clinic, and the birth injury called cerebral palsy. And the reporting and learning system for cerebral palsy is very unique because it comes with financial compensation, monetary compensation. We pay a damage payment for a patient and the family in this system, regardless of negligence. So in other words, we do not discuss the negligence. So in that sense, this system is called no-fault compensation system. And what is important is that we focus on, we highlight co-production and co-creation with patient and families. So all these projects are operated by steering committee in the presence of patient representatives in JQ. And next, I'd like to try to move to the next slide, but I don't know why it doesn't move. I'm sorry. Next slide. I'm sorry. Okay. JQ, as I said, JQ is an accreditation body, and ISQA is accreditation body for accreditation body in individual countries. So JQ is accredited by ISQA together with other international accreditation bodies in many countries. Next slide. Okay. In the year of 2000 and around, a deadly accident that took place in Japanese prestigious hospitals like university medical centers was very much highlighted by Japanese media. So, we observed rapidly growing concern on patient safety in our society. So, in response to the concern, the Japanese government, particularly Ministry of Health, launched the comprehensive policy, holistic policy on patient safety promotion in 2002. And it depicts the roles of citizens, roles of patient and family, roles of manufacturers, roles of healthcare providers, and the roles of governments. And it clearly mentioned in hospital reporting and learning system as well as national reporting and learning system. And the next slide. It takes time, so I'm sorry. I don't know why it takes time. Okay, so now you see that there are two levels of reporting and learning system, the institutional level and the national level. National level is run by JQ with government subsidiary budget, and then I'm in charge of both reporting and learning system, and it is quite important to have robust organizational structure on patient safety at your institution. Here in my hospital, Kyushu University Hospital, the organizational structure on patient safety is directed by hospital director, and I work as a deputy director of the hospital and the chief patient safety officer, and we work together with safety managers of nurses, dentists, and pharmacists. Particularly, 4 nurses and 1 pharmacist are working on full-time basis, and 1 dentist is working as on part-time basis. And then we have 2 risk managers on individual department, division, and unit. So totally, we have more than 100 risk managers in my hospital. So next, I'm going to the next slide. Next slide. Okay, here you see the patient safety manuals, like a notebook, which describes incident reporting flow and the committees relevant to incident review. So some of the very serious incident goes to incident review committee. However, others are processed on our regular meeting or on our regular patient safety promotion action. And then if you take a look at the manual, we grade the incident from 0 to 5. 0 means nothing, and nothing happened. And 5 means patient were dead, unfortunately. And then if the level 3B or beyond take place, the case is quickly shared with hospital director and me, even at night. And then here you see the photo of me taken taken in April. So the cherry blossom is in full bloom beautifully. And here you see the manual notebook. It's in my pocket. So we call this manual a pocket manual or in pocket manual, and we carry it all the time. We have 3,500 employees in my hospitals. All the employees, all the staffs must carry this in-pocket manual in their uniform. And we also have big patient safety manuals, which is really big. But it's on the bookshelf. However, we cannot bring the big manual everywhere. So the in-pocket manual is really helpful. So with that policy and based on the manual, we receive 350 to 400 or more incident reports on monthly basis in my hospital with 1,200 beds. And as I said, if the serious incident take place, the case, the incident is quickly shared, even at night, through email to me and the director of the hospital. This is the example of the email. What happened is that this is a mail sent from a safety manager, Mr. X, at 18:40 p.m. The patient underwent living donor kidney transplantation, but I think the big hematome was formed, and the patient suffered abdominal pain, and the blood pressure rose up to 170 and 180, very high. So physicians planned to lower the blood pressure by medication and continue to observe in recovery room with careful monitoring. And hours later, there was no growth of the hematome, which is really good. However, the pain continued. So the physician and their team worried about hematome large enough to press the kidney that could lead to failure of the renal function. Therefore, the team made a decision to conduct emergent surgery in expedited manner to remove the hematome. Well, this is a story or report which was shared with me and the hospital director and the safety manager in the division of patient safety. So the report like this is always shared very quickly in my hospital. And with that report, we produce the meeting material for monthly meeting on patient safety. Here you see here you see the form, the document form of adverse event, and here you see the description of incident in detail, and the probable cause follows, and the corrective action also follows. And there is a note note on similar event in JQ's database that I'm going to touch on later on. And the complication is shown in very simple form in this in another material. And then this is also a very detailed document of incident with graded level 0, 1, 2, 3A. And there is a title, description, and corrective action, and a comment by safety managers. So the documentation for the monthly meeting is quite important to share what happened, what is happening in my hospital. And with those cases, we produce on monthly basis alerting material in my hospital. Here you see 3 different alert for 3 different months. Here you see on your left the alert on inadequate application of clinical pathway to a patient, and etc., etc. In the interest of time, I'm going to the next slide. And what here you see the agenda of our risk manager meeting last year. For instance, the agenda includes the presentation of recent patient safety incidents with documentary materials I showed previously in slide. And then Kyushu University Patient Safety Monthly Alert is also included in the agenda that I showed in previous slide. Okay, here you see the photo of the meeting committee or risk manager meeting in my hospital. Here you see the photo of patient safety committee chaired by hospital director. I'm sitting here. And then here you see the risk manager meeting joined by more than 100 risk managers in my hospital. I normally chair risk manager meetings, and the agenda was showed in previous slide. And here you see the meeting documents of risk manager meeting that have happened last year. And for instance, the incident statistics is included, and the list of individual incident that I showed as a document in detail previously. And this is the outcome of incident review committee. Yes, I said some serious incident, severe incident goes to incident review committee, and discussion is shared in risk managers meeting, in a way like this. And yes, this is the sort of a study agenda to learn again about Kyushu University universal rule of physical restraint. And here you see JQ's monthly alert that I'm going to touch on later on. It is one of the agenda. And here you see the report from Monitor Alarm Control Team. This is a report from working group on Monitor Alarm Control. And then here is the update on my activity on global occasions. Here you see the photos of my presentation in which I made in Ho Chi Minh, Vietnam last year. So maybe I'm going to share my experience in this Saudi Arabian webinar in risk manager meeting next month. And we also we also confirm the circulation of our materials, such as monthly alert and other products by patient safety round. And we produce checklist, and we goes to all the department of the units twice on annual basis. And then we confirm if the products or information or knowledges are really shared at all the patient ward by patient safety round. And here is also the photograph of the round. The rounding person is now confirming the poster or posting materials on the wall. 5R for medication safety is one of the posting materials. Notification flow on critical laboratory data and the pointing and calling verification procedure, and 5S Kaizen. And JQ's monthly alert is one of the posting materials, but it's included in a special file. And if our staff confirms JQ's alert, they need to put their signatures here in this document. So our staff confirms staff signatures in patient safety rounds to see if the very important information or knowledge or data is actually circulated and shared and penetrated at patient safety ward. And I have now talked about the incident reporting system and the product sharing at institutional level in my hospital. So I'm now moving forward to the national level reporting and learning system. The original system was launched in 2004, and because this original system was really, really successful, so the government came to JQ to launch another reporting and learning system for pharmacy and dental clinic and birth injury, cerebral palsy. And another organization launched investigation system. This is sort of a reporting and learning system only for accidental death. And I am helping the organization in conducting this project with my knowledges and expertise. And in addition to national level reporting and learning system by JQ and another organization, I would like to add one more reporting system for pharmacovigilance. The system is run by pharmaceutical and medical device agency like FDA in the United States. We call it PMDA in my country. So the report is mandatory to PMDA, and the side effects or defects in medical devices are reported to PMDA, which is government agency. And here you see the government regulation under the evidence for mandatory reporting. So in the interest of time, I am going to skip this slide. And so in a nutshell, the product reporting related to product issue, product error, or product defects is reported to PMDA, while human error is reported to JQ, which is a private body. And we Japanese medical professionals likes private organization better than public organizations, because public organizations like PMDA under the central government is authorized to penalize medical professionals as well as medical institutions. So we like private body like JQ, which is not authorized to penalize medical professionals and institutions. So it is true that JQ's reporting and learning system that I have been in charge of is collecting a lot more data from medical institutions than PMDA. So I'm sorry, this is very exhaustive slide, but the message is really simple. We collect a lot of data from medical institutions, and we disclose the data on our on our database. It's disclosed to anybody, any organization. So it's disclosed to you. So you have an access to our database. And so the PMDA leverages our database, and together with the data PMDA collects from medical institutions, and they work for regulatory job. That's the message of the slide. And now I would like to focus on our national reporting and learning system of JQ. I'm sorry. I'm sorry. I'm trying to. I'm sorry. Okay. Our reporting and learning system is composed of two groups of medical institutions. The first one is mandatory reporting institutions, and second one is voluntary. Mandatory institutions is not many, only 270, whereas more than nearly 4,000 institutions joins our reporting and learning system on voluntary basis. And then we have successfully observed the steady increase in the number of adverse events. And we also collect near-miss event in addition to adverse event. Near-miss event doesn't increase, whereas adverse event, including the fatal cases or malpractice cases, increases steadily in my country. So we see this increase successful outcome of this reporting and learning system. So here you see the video and group photo of the Alliance of National University Medical Center for Patient Safety. It's called JANUFA Patient Safety. And these institutions, National University Medical Centers, are reporting a lot of adverse event and near-miss events to JQ's reporting and learning system. So I would say they are the driver for successful reporting and learning system. So in order to have successful reporting and learning system, you need to have core members or robust reporting resource in your system. So this is the reason why our adverse event reporting exhibited steady rise. Probably the reason number one is strict adherence to no blame reporting and anonymous reporting. Those two principles are preserved in JQ. The medical professionals like to report to JQ, and the January PS, January Patient Safety, has been a key driver for reporting, and repeated call for registration through a series of lectures that I made across Japan. So more than 10 years ago, I made 20 to 30 or more lectures on reporting and learning system and the value of reporting and learning system on annual basis in my country. And we never fail to deliver feedback to medical professionals and the institutions because the people do not want to report without any feedback. So the feedback is quite important, and pressure on medical institutions for registration by media and patient and family and lawyers, and the guidance instruction by local government through annual or regular inspection. I said JQ is private body, but the central government and the local governments authorized to issue guidance, deliver guidance, or even order medical institutions or medical professionals to do something. And the local government conducts annual inspection or regular inspection every 3 years to small clinic or big hospitals. So on that occasion, they facilitated, they encouraged these institutions to participate in this reporting and learning system. And the last but not the least, enhance the transparency by providing data for practical and research use to the healthcare funds and the research institutions, etc., etc. So those are probably the reasons of successful reporting and learning system. And with the reports, we publish a regular report, quarterly report. And if the similar case happens again and again and again, we highlight those repetitive, recurrent event in a chapter called Thematic Analysis of Recurrent Event, as well as thematic analysis. And then we also produce monthly alert, as I said. And if monthly alert is related to recurrent event, so the monthly alert is included in this chapter. So the people, medical professionals will see many times of the same case or similar cases because those cases happens again and again in my country. And we have published the nearly 80 quarterly reports and the 19 annual reports, and that includes more than nearly 300 individual thematic analysis and 150 recurrent themes. And here you see the thematic analysis. For instance, in 77th report, we highlighted wrong prescription at the transition of care, i.e. The discharge or later in other institutions or some other places. And when we take a look at the thematic analysis, it includes many informations. In the interest of time, I'm going to skip on details of pages of thematic analysis, but I would like to stress that it includes many tables and individual cases in details, and the corrective actions reported from the institutions. And this report and thematic analysis is shared among medical institutions in my country. Here you see the WHO report that highlights the medication safety. And the WHO also stressed that after patient's discharge, their prescription is transcribed or documented, but it could change. And after admission, it also could be changed in such a way that when a patient is admitted to the medical institutions, prescription is verified by pharmacist, and most of the drug is continued on admission. However, many alteration or changes are made on prescription depending on patient's conditions in such a way of one drug deleted again, new drug added, and at the patient discharge, the altered or changed prescription is communicated and verified, and the patient discharge home or to another medical institutions where the similar changes take place. So here you see the government policy in aging society in my country to emphasize that patient is given a care from different bodies such as hospital, clinic shown here, and home visit nursing care office shown here, nursing care facility here. And if patient is taking medication, the alteration or change in medication happens in all these facilities in aging society. So the reporting and learning system and the thematic analysis on the medication at the transition of care is quite important. I would say this is infrastructure in aging society, like society in my country. And then I would like to move on to the monthly alert. Here you see the monthly alert. I would like to emphasize that the illustration is always included in a monthly alert. And people say that they use monthly alert. Yes, nearly 100%. And how they circulate our JQ's monthly alert. They said they circulate among all the staff, among relevant clinical departments, and among people other than staff. So our monthly alert, JQ's monthly alert, is really popular and circulated in medical institutions. As I said, in my hospital, the JQ's monthly alert is one of the agenda of patient safety committee or risk managers meeting, and it is delivered to patient ward, and our staff has to put their signature when they confirm JQ's monthly alert, as I said. Okay, we have produced more than 220 monthly alerts. So there are many alerts. So we needed to have better way of display. So we got two different perspectives. Such as general classification like monthly alert related to drug or laboratory test or surgery, etc., etc. And another perspective is specific clinical practice, such as pediatric care or insulin administration, etc., etc. So if you take a look at our website on our monthly alert, here you see the general classification. If you click medication, you will see monthly alert related to medication. And then there is another homepage. It's a specific clinical practice in relation to our monthly alert. If you click pediatric patient, you will see 6 monthly alert on our website. And there is another way of display recently launched on our website, which is the JQ's alerts edited and embedded in a lot of medical institutions. So we provide our alerts and our illustration of alerts for free of charge for patient safety use. And so medical institutions produce their own alert, embedding a part or all of our monthly alert. Here you see the alert of one medical institutions, which clearly includes JQ's alert. Here you see another the alert of another medical institutions, which partly includes our our alert, JQ's alert shown here. You can see these examples on our website. And here is another type of monthly alert, which reflects on the alerts issued the previous year in March every year. So here you see the title of alerts issued previous year, and here you see the star mark, which indicates titles of record events, which is provided in details on page 2. So record event, I mean the event which took again and again is shown displayed on page 2. And here you see another type, another type of monthly alert, which reviews all the 220 alerts. And if the similar case happens, those cases are included in alert in June every year. So if you take a look at the alert issued in June every year, you will see what type of alert is repeating in my country. And JQ's alert is obviously included in our risk manager meeting or meeting related to patient safety in Kyushu University Hospital. And here you see the documents of risk manager meeting again, and the JQ's monthly alert is included here. And okay, I will now go to the database. We produce database, and we disclose all the adverse event and the near miss event on through our database. And then our database is highlighted not only by medical professionals and researchers, but also by manufacturers, because their products appears in our database. Here you see the alerting material issued by 2 different pharmaceutical companies, Taiho and Pfizer. It says that in a title, it says that mix-up of prescription of sound-alike medications, Loicon and Loicovolin. It's really hard for me to distinguish one from another. Loicon and Loicovolin, they sound very alike. And then, but the illness they are effective for is quite different. So this is a very important point. And I'm sorry, I go back. And our data on our database, in other words, reports on our on JQ's database, is cited by manufacturers on this alert. And then manufacturers delivered a message saying that we suggest that you medical professionals type at your computer Loico and Loico instead of Loico on ordering prescription. And please note that 3-character typing, such as Loico, is the norm and the very usual for safer prescription in my country. However, for those 2 sound-alike drugs, manufacturers suggest that we type Loico plus N, Loico plus VO, instead of Loico on ordering. This is the message delivered by manufacturers. And as we have disclosed many incident cases on our website, one day researchers on AI came to me from Hong Kong, and Dr. Won Sui, she's a researcher on artificial intelligence, and with our database, we launched a joint project on developing AI to analyze incident case, particularly medication error. And here you see the development of BERT. This BERT and ChatGPT has common origin, which is called transformer. And we pre-trained the BART, and we fine-tuned the BART into steps with our database. And then we produced AI models. Now how it works is that if we put one incident case, the AI models tells me that, oh, here you see the word Monday. Monday is the date. Here you see levofloxacin. It means drug. And here you see cefpodoxime, which is also drugs. For instance, it also tells me that 20 milligram is the amount of drug that physician intends to administer. Another 30 milligram is the amount of drug that was actually administered to the patient. So 20 milligram and 30 milligrams are different. So this is the case of overdose administration. So this is our AI models tells us about. So we are trying to further develop our AI models because the data set will help extract look-alike drug and sound-alike drug and the incident on opioid and more. And electronic health record will identify medication errors powered by our AI models. And our methodology will help in annotating other human factors that causes error, fatigue, distraction, etc., etc. So we are still engaged in developing advanced AI models with our database. So we published a scientific paper stating that our database serves as a valuable and unique resource for systematic studies of medication errors around the world. You have an access to our database, and you can use our database and data. Although it is written in local language, however, you can translate it into English, and you can use it. And in my country, one of the Japanese companies produced AI model for Japanese PMDA, Japanese FDA called PMDA to help their work. So this is a newspaper article that tells us about their development of AI models to help PMDA. So our database is available and very useful among healthcare society in my country. And as I said, we have equivalent reporting and learning system for community pharmacy and the dental clinic, and birth injury. And as I said, the birth injury reporting and learning system comes with no fault compensation. And what is unique about this system is not only no fault compensation, but also production of investigative report. Very detailed investigative report is produced by the experts and is delivered not only to childbirth facility for learning, but also to patient and families for learning about what happened during delivery and what quality the procedure was during delivery. And in order to share our products across my countries, we periodically hold press conference like this. And then the central government is really cooperative with JQ to circulate and spread our products by issuing MOH divisional notice to request local government for circulating reports and alerts, and the local government kindly circulates those products among hospital, clinic, birth centers, etc., etc. And then I made a presentation on our reporting and learning system in April on occasion of a ministerial summit on patient safety, which is a high-level meeting joined by health ministers for patient safety promotion. And my organization under the Japanese government held the ministerial summit on patient safety in 2018, and more importantly, our summit was followed by Saudi Arabian summit, which took place in Jeddah, Saudi Arabia. And I visited Jeddah and I made a presentation on patient safety activity in my country in Jeddah. So I really thank Saudi Arabian colleagues for holding the summit meetings and continue the baton and momentum on patient safety to the next summit. And our reporting and learning system is now popular among other countries like United Kingdom. And here you see the homepage of investigation body in National Health Service, NHS, England. And one day I was asked to produce a blog manuscript on reporting and learning system in my country. So if you visit their website, you will see my blog. And it includes the overview of our system and the staff signature page of for JQ's alert and manufacturer's message making use of our database. And the no-fault compensation system is also introduced in my blog. So it's also posted on the website of investigation body of NHS England. And my friend, Dr. Dr. Ulfat Sheikh of the University of California, Davis, asked me for joining her podcast. And I described our reporting and learning system on her podcast project. And in 2021 and 22, particularly 22, I was invited by the UK Parliament, the select committee of the House of Commons of the UK Parliament, to describe our reporting and learning system, particularly a no-fault compensation system, together with other international experts running no-fault compensation in Sweden, United States, and New Zealand. And then in 2023, our system was included in a renowned annual report on global patient safety issued by Imperial College London. Our no-fault compensation system was included in 9 case studies in their report. And last year, I joined the 6th Ministerial Summit on Patient Safety, which took place in Santiago, Chile. And I described our reporting and learning system, particularly no-fault compensation system, in the plenary session. And here you see the WHO Global Patient Safety Action Plan, which is a 10-year action plan by WHO for patient safety promotion. I'm a member of a developing working group of this 10-year program, and it highlights reporting and learning system as shown here. And then in 2 years later, WHO published a progress report that exhibited that only 32% of member countries is now running incident reporting system at the national level. And if you take a close look at the report, the Thailand delivered statement saying that in 2016, Thailand is inspired by a WHO consultation and the Japan's reporting and learning system, which is our reporting and learning system. And Thailand launched national level reporting and learning system. Okay, this is all I have brought to you on this valued occasion. So I'd like to skip this the last slide. So thank you very much. Thank you for joining and listening to me. Thank you very much. Okay, I'm going to stop my sharing. Thank you very much. Over to you, Abdullah or Hiba.
Thank you very much, Dr. Yoshiro. Now we will move on to our next speaker, Mr. Abdullah Zahrani. The floor is yours.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. Good afternoon, everyone. It's my honor to speak with you today about how we are working to improve reporting and learning system. And thank you, Prof. Shiro, for sharing the experience of Japan. It was really inspiring. I will share my presentation. Second. Do you see the slides?
Yes, it's clear, Mr. Abdullah.
Thank you so much. So before I begin, I would like to highlight the goal that's shared by Professor Shin Ishiro, who has joined us today. His experience in building strong patient safety system in Japan is very valuable for us. His research focuses on creating trust, promoting teamwork, and learning from incidents without blaming individuals, values that are essential in any successful safety system. This is the most important question, why patient safety matters today more than ever. So research says that every year more than 134 million patients suffer from harm in low and middle income countries. And as you can see, there are two key reports. The first one is Crossing the Quality Chasm in 2001, which was following the To Earth Human report that's stating 44,000 to 98,000 Americans dies yearly because of preventable medical errors. So the harm is estimated to be 1 in 10 patients being harmed from healthcare, and it's preventable harm. So estimated in the high-income countries that there is 134 million adverse events yearly. That leads, unfortunately, to 2.6 million deaths yearly. In the low and middle income countries, it's approximately 2/3 of all adverse events occurrence. Prof. Shen shared already the 7 objectives from the key report from the Global Patient Safety Action Plan, the 10 years action plan. And most importantly, that we look at strategical objective number 1, making zero avoidable harm to patients, a state of mind and rule of engagement in planning and delivery of healthcare anywhere. And as well, strategical objective number 3, which is assuring the safety of every clinical process. As mentioned by Prof. Shiro, the Global Ministerial Summit on Patient Safety started in London 2016, and in 2019 we had the Jeddah Declaration, which was already approving the points that have been discussed in Tokyo in 2018. The main goals and objectives for these declarations were promoting patient safety, utilizing digital health to support patient safety across the globe, promoting patient empowerment and community engagement for patient safety, leverage the international classification of disease throughout the creation of disease reporting for patient safety, which is international classification of adverse events. I will not go through all of these 11 goals. So in research, there is a negative correlation between patient safety culture survey and patient safety events, which is showing in this graph. So the hospitals, they have higher patient safety culture they are having lower adverse events. This is taking us to the concept of high reliability organizations. So we are standing in reporting phase, which is requiring the healthcare providers and the frontliners to report events, which is according to the 4 components by James Reason, that it should take us to the just culture, whereas there is no blame for the individuals. After that, this is taking us to the flexible and teamwork culture, which is gained by through a systematic training like team steps. This is taking us to the learning organization, which is effective reporting and just culture create atmosphere for trust, and the sense making of patient safety events, and taking us to the high reliability result. Now we'll talk about the shape of the healthcare system in Saudi Arabia. The total area is 2 million square meters, with a population of 34 million, and we have more than 500 hospitals and total beds of 77,000, with millions of visits in the PHCC and the outpatient department, and also inpatients. We have 3.1 million. These statistics were shared in 2001. And also we have multiple providers in the healthcare system. So the Saudi Central Board for Accreditation of Healthcare Institutions mandate that the implementation of facility-based safety reporting system, and these are the manuals for national standards for hospitals, primary healthcare, and as well the home healthcare services. Saudi Patient Safety Center shared the Patient Safety Standards book, and in criteria 1.1, the organization deploys a systematic approach for investigating patient safety events, and the mandate of having a tool to report safety events. This is the MOH hospital commissioning checklist. It's including as well the availability of reporting system in each hospital. So all of these mandates are paving the way towards having safety reporting and a system of reporting or a mechanism to report safety events. As well, to unify the language, the Saudi Patient Safety Taxonomy, which was released, and it's already in the website of Saudi Patient Safety Center. So we have 29 domains. Under these domains, we have 35 categories and 550 categories with 300 plus details. This will unify the language and make it easier for the next step of having a unified reporting. The harm level is taking for non-clinical, none to catastrophic harm, as well as utilizing the NCCP MRP for the medication related incidents from E to I. This will make it easier for the providers to report incidents. So looking at the system of reporting, we have mixed methodology of reporting, either hybrid reporting system, mixing papers and electronic, plus we have paper-based, and we have electronic, completely electronic system, and we have email-based in some of the institutions. This is taking us to the challenges of patient safety, where we have fragmented reporting systems, and the rates of avoidable injuries and non-communicable diseases, plus the inadequacy and inconsistency of primary care patients flow. So the patient is moving from facility to another facility without tracking the safety events or the harm that he got through. Plus the gap in quality services provided to the patients, and fragmented systems and leadership commitment, the cultural resistance to change, the digital health infrastructure, and so on. So how to improve it? By enabling healthcare workers to report safety events and having them or giving them an easy access for reporting these incidents, plus having the non-punitive manner when reporting an event, which was clearly explained in the previous presentation by Prof. Ishiro, as well as enhancing the learning, so disseminating the information and sharing the reports among health system, so we would have an active learning organization. This is taking us to system-wide improvement by understanding the priorities and what can we do to save the next patient. One way also to improve the safety events reporting by having more awareness among healthcare workers by giving them the feedback of their reports. As you have seen before, that there is a positive correlation between culture and positive culture and reporting, as well as decreasing the harm in the organizations. So the main goal is to have a safety culture, but this is interlinked and connected to many other systems and sources. So the trigger tool, the safety events, root cause analysis, patient complaints, physician productivity, morbidity and mortality review, how we can connect the dot and get all of these systems working together to give us more of full picture and having an holistic approach to the whole system and to the harm that produced in the system. The last slides I will talk about the steps that should be taken in the future. So one way is to have an electronic triggers where you have the electronic health records equipped with the needed tools to provide proactive surveillance. So we wouldn't wait for an event to be reported by the healthcare provider, but we can capture it through the system by auto-detecting as well the high-risk patterns and routine data. An example for medication triggers, if an naloxone was used and investigated, why this would take us to either medical decision or a potential avoid of overdose. If there is a higher INR, this might take us to warfarin use and the bleeding risk, as well as laboratory triggers like sudden creatinine raise. This is possible nephrotoxicity, critical potassium sodium. This might go with unsafe electrolyte handling. Many nursing triggers like fall, restraints, pressure injuries, changes in the GCS. This is also would work in the early warning signs and triggers. So if we have all of these triggers by the system, this will give us fewer harm and faster learning, and supporting the just culture. So we won't wait for a staff to report an event, but the data will lead to detect the event, and there will be no blame and no individual involved in reporting these events. as well as using the AI solution, using the NLP models to scan the clinical notes, extract keywords related to harm and near misses or unsafe care. The use cases can be used to identify undocumented events, correlate emotional tone from the nursing note with the risk escalation, and detect duplicated entries, including system delays. It can go through these notes and find the patterns and identify triggers through them. By this, I concluded the presentation, and we would go through the panel discussion. So, Prof. Shiro, we will go through the questions by the audience.
Yes, sure.
And, so kindly, if you have any question or any note, please write it in the comment box. There is one question, Prof. Shiro,
Yes.
from Dr. Ghadir. Says, I'm familiar with the RCA as a method for identifying the underlying causes of problems, especially in healthcare setting. But since you have a broader perspective, I would love to hear your insight. Could you please enlighten us more about how you see the RCA methodology being applied effectively, especially in decision making or risk management?
Yes. Thank you very much for your question. And I also looked into the chat box, and I successfully identified exactly the same questions. And RCA, root cause analysis, is really popular in my country. There are many books written in our local language on root cause analysis. And in our reporting and learning system, we provide education and training occasions where participants learn about root cause analysis. So more than 20 years ago, in my country, no blame culture was not there. And then people blamed individuals when serious incident took place. However, root cause analysis, the idea of root cause analysis changed those old idea or conventional idea dramatically. And we got aware of the value of system-based approach, which is delivered by root cause analysis. So the method, not only methodology, but also the idea of root cause analysis or failure mode error analysis have been spreading very rapidly and still spreading in among medical institutions in my country. So that's one thing. And now we see another theory on patient safety called patient safety 2, in contrast to patient safety 1. And patient safety 1 emphasizes the error correction, and the patient safety 2 highlights the raising the likelihood of successful practices, successful working flow. So the idea of patient safety 2 is also rapidly spreading in my country. I think this is the updated knowledge on global basis. So in those trend, the root cause analysis played a very important role, particularly in the initial years or when we began promoting patient safety in my countries, and JQ is still providing opportunities to learn root cause analysis to medical professionals in my country. So, so thank you very much. So, it's quite important for me and you to learn about root cause analysis and implement it on daily clinical practices. So, thank you very much. Over to you, Dr. Abdullah.
Thank you, Professor Shiro. I have one question for
Yes.
regarding the experience of Japan.
Mhm.
So, in terms of learning system and the lesson learned from the safety events, how you manage to get the feedback loop in terms of the implementation of these actions when you send an alert to an organization. So how you get the feedback loop for action implementation.
Okay. Thank you very much. And in JQ, I'm in charge of national level reporting and learning system. And as I said in my presentation, the products, such as monthly alert or the periodical reports and the database are shared among medical institutions with the help of the central government, local government, hospital associations, professional associations, etc., etc. And those products are successfully delivered to medical institutions. But the question is how those products are utilized or fully utilized or embedded in daily practices in those institutions. We still have a challenge on this issue. However, in my hospital, the patient safety committee risk manager meetings are effectively working. I need to add patient safety rounding, effectively working to embed those products or those informations on patient ward, the front line of medicine. That's the way we produce and share and implement and confirm the patient safety knowledge and the practices that is produced through national level incident reporting and learning system. I hope this experience is helpful to participants. So thank you very much.
Thank you so much. And
Thank you.
mentioned safety walkarounds, and I can see here one of the questions from one of the audience that asking for one advice to improve our skills as risk manager and how to make change in our hospitals.
Okay. Yes. Thank you very much. Yes. It's a really a great question because there is no quick answer. But first, I'd like to mention the team approach. You know, the individual risk manager is not very effective in terms of convincing medical professionals like physicians to act on patient safety promotion cooperatively with individual risk managers. However, if you have big structure in your institutions under the leadership of the hospital director, the individual managers is able to work more effectively for patient safety promotion. So in a nutshell, you need your friend to work with, and you need leadership, which comes from hospital director or deputy director in charge of patient safety, like me, and you work in a big team to convince medical professionals to engage in patient safety promotion. And it is also helpful to introduce knowledge and expertise or experience from other institutions or from national systems, because if you discuss with their colleagues only internally, it's quite difficult to promote patient safety, because people emphasizes their situations very strongly, and it's reasonable to some extent. However, um, the situation is quite different very often in other hospital, in other clinic, or at the national level. So the perspectives of introducing experience and knowledges from other organizations or external bodies or national level projects are quite important to enlighten your staff to the external progress on patient safety. I think that is very helpful, and I have been taking that approach in my hospital. So thank you very much. Good question.
Thank you so much. I would like to add that patient safety is not solely for quality and patient safety department, and everyone in the hospital and every healthcare provider is a risk manager. So in that context, they would have all the responsibility and not just giving it to certain people in the organization to manage. Totally agree with you, Prof. Shen.
Yes, I agree with you, Atsuya.
Thank you so much. Before we go to the next question, we'd like to learn from you how you managed to overcome the challenges in terms of enrolling the safety reporting system in Japan, in terms of the technological issues, having all engaged in this system. Thinking of the reporting in terms of technology and connectivity, especially in rural areas.
Okay. Well, thank you very much. And with the government subsidiary budget, JQ produced web-based reporting and the learning system, and it's available everywhere in my country if they have a connection to the internet. So regardless of the size or location of the medical institutions, they can report to JQ if they have internet connection. However, if the institution is very small in scale, it might be difficult to collect all the informations that JQ require to describe or input. Our reporting system have text data page and coding data pages. So small institutions may see it difficult to collect all the coding data from incident case. So the most of the participants in our reporting and learning system are middle-sized and large-sized hospitals. So we still see only in a small number of small-sized hospitals in our system. However, as I said, we launched a reporting and learning system for dental clinic, and we see big number of participants of dental clinic, which is very small organization. However, there is a reason, there is a trick, which is the financial incentives by public healthcare system. So if small dental clinic joins our reporting and learning system, they will get more money from healthcare insurance payment system. So we see increasing number of small institutions in our dental reporting and learning system. So I think financial incentive works very well. You're on mute, Dr. Abdullah.
Sorry for that. I see the time running
Yes.
fast, but we enjoyed this presentation. I would like to ask for, I have one question here and plus another question
Okay.
side. Did you have any statewide improvements from the safety reporting and learning system? Yeah, and the other one is I can see here there is one question related to AI and the technology, and I'd like to. Earlier we talked about the impressive work that you have been doing with the Japan using the NLP to analyze clinical incidents. If you'd like to highlight. Thank you so much.
And in my presentation, I demonstrated the steady rise in the number of adverse events. So the case is still increasing. So it's probably this is caused by underreporting reason. So in condition of underreporting, it's difficult for me to say the improvement in some types of event. But we are following the similar case happening related to the monthly alert or thematic analysis that we produced. So we hope that if we publish monthly alert or thematic analysis, the case will decrease. However, in the situation of underreporting, we still see the case rising. So it's difficult for me to improve. But we can clearly say that culture of reporting is improving, evidenced by the increase in the number of adverse events. So the previous year, medical institutions did not want to report. However, this year they want to report. So that's the reason why we see steady increase in the number of reporting. And the Japanese patient, media, government, and the society welcomes and touts that increase because the culture is improving. So this is sort of an improvement. And I mentioned specific cases on sound-like drugs. And in relation to some combination of similar names of drug, it happened that one company removed their brand name from the market to remove the sound-like drugs. So the brand name is quite important for individual pharmaceutical companies. However, for patient safety reasons, there are a couple of companies in my countries who removed their brand name to eradicate a sound-like combination in the market. So I think that's the cultural change and improvement of the behavior of pharmaceutical industries. Yes, I would like to share those experiences. So back to you, Dr. Abdullah.
Thank you so much. I think we are running out of time. I
Okay.
don't know if we can have more minutes. Ms. Hiba? I can see one question here we can
Okay.
end up with, which is from Ghadir again. Do you have a list of clearly reportable sentinel events, especially in case where there is a gray area and uncertainty whether it qualifies as an adverse event or not? And when preparing the action plan, do you typically involve the frontliners who were directly involved, or only the field experts?
Okay. And if I understand your question clearly, you first asked about the incident which is uncertain in terms of the eligibility to criteria. But we are not very much strict about the definition or criteria. So if we encourage medical professionals and the institutions to report if they believe that the case is helpful to improve healthcare in our country. So if we focus too much on the conformity to definition, we waste too much time. So we are really flexible and generous to that point. And another thing is that, yes, we involved medical professionals working on the front line of medicine in our steering committee and experts committees to produce good, very helpful and helpful and effective knowledges that really works for the front line of medicine. That is quite important. So we do that, include those experts. Thank you very much. Over to you, Abdullah.
Thank you, Prof. Shiro. I would go also to the same question. We have a specific list, and also, as you mentioned, the definition for the sentinel events. So the question where, if I understood it correctly, it was sometimes we have a gray area. Is it an event or not? But as you mentioned, we encourage also reporting these events, which will benefit. So if you have a doubt about an event, sentinel event or not, we go with reporting this event.
Okay, great. Thank you. Yes, I support your idea. Thank you.
Thank you. And by this, I think we had we finished the time, and to give the mic to Ms. Hiba.
Thank you so much. Thank you so much, Mr. Abdullah and Dr. Yushero. On behalf of the Saudi Patient Safety Center, we extend our sincere thanks to Dr. Shen Yushero and Mr. Abdullah Zahrani for their active participation. As part of the Saudi Patient Safety Center's effort to provide you with the timely topics and interesting speakers, we would appreciate it if you would fill the evaluation in the chat. In the chat. Thank you again for joining us today. We look forward to welcoming you again next time. Thank you.
So thank you very much. Thank you, Dr. Abdullah and Hiba, for taking care of, for including me in this valued session. Thank you very much.
It's our pleasure.
Thank you, Prof. Shiro. Thank you, Ms. Hiba. Pleasure meeting you. Thank you. And thanks for the audience.
Thank you so much. See you next time.
See you.